Welcome to Health Oddity, the show that strips away the jargon and hype surrounding all things health and fitness to help you live a long, strong and energetic life. Lining up at the bar this week, here's Peter Lant, Paul Bassett and James St. Pierre.
Hello and welcome to the Health Oddity podcast, episode 51. We are closing in on our 1 year birthday, and we are continuing, I think, this whole 2021 now. So far, we have had fantastic guest after fantastic guest, and this week we are really kind of closing in our first year with one of the most distinguished guests we have had all year. And I do have to say we have had some fantastic guests already, but this guy, when I introduce you, I guarantee you that if you are a human being over 40, you are going to find this episode incredibly beneficial and interesting. First of all, I'm going to introduce our usual co-hosts, Mr. Peter Lant. How are you doing, sir?
I'm all right. How are you?
I'm very good. And you've actually had a haircut for this episode, because usually you don't look anywhere near this sharp.
I don't do it. I've got there's a collar on my shirt and everything. It's amazing.
Not even for Jet. I mean, when we had Jet on, I mean, come on.
Yeah, well, you know, I'll let myself down then. Never mind.
And we have Mr. Paul Bassett joining us as usual from London. How are you doing, Paul?
I'm all right. I'm pretty excited about today. It's a subject close to my heart, and I'm just going to listen and soak it up.
Excellent. And joining us all the way from, I think, Ontario, Canada, is Professor Stu McGill. How are you doing, Stu?
Absolutely fabulous. Thank you very much.
Okay. So for those of you, I mean, if you are a trainer, if you are a clinician, if you are a therapist, I'm sure you are aware already of Stuart McGill's work. But Stu is the professor of biomechanics at the University of Waterloo. He is BackFit Pro. He has spent his whole, well, we're going to find out more, but a big chunk of his life understanding the spine, understanding back pain, understanding the causes of and the roots out of back pain. And I think if the three of us hosts, if we've all got Stu's book here, I think, have we?
Yeah.
There you go. Yeah, okay. We have all got one of Stu McGill's books called Back Mechanic, which we just held up. And Stu is doing very kindly joining us early in the morning, or early-ish in the morning over in Canada. It's the afternoon for us. So welcome to the Health Oddity podcast, Stu. And can I just ask you, I mean, initially, just to kind of tell us a little bit about yourself. And, you know, you've already mentioned just before we pressed record, you know, you're working with, I know you work with active athletes, active fighters, you work with powerlifters, you work in a clinical setting, you've worked with Olympians, with professional athletes from all kinds of sports. But how did you get to where you are today, and what really sparked this interest in the mechanics of the spine and back pain?
I wish I had a nice, tight little answer for that, but I don't. Like many things in life, it's a matter of meeting the right people at the right time. But as a foundation, I've always been interested in how things work. So I started a PhD in spine biomechanics, only asking one question: how does the spine work? And from there, I got into bigger questions. Well, when it doesn't work well, what's gone wrong? What are the mechanisms of pain or loss of resilience or compromised performance? And as a corollary, what are the determinants of performance and resilience? And then, after being a professor for maybe 8 or 10 years or so, different clinicians and organizations would say to me, would you see a stubborn patient with us? Because what you just published or showed as a mechanism seems to be relevant for this very challenging patient, or this person who was a former gold medalist and now they're quite crippled. And I said, well, no, I'm not a clinician. And they said, well, don't worry, we'll come with you. And that was the beginning of my clinical career. And now, prior to COVID, in in any case, different medical schools around the world would ask me to come in. Would you see 3 patients in front of our staff, and we want to see how you work? And usually they've never seen an assessment like what we do. The art of assessing back pain, back function, both very resilient, high-performing backs, but also very disabled, compromised backs as well. The art has gone. If you went to an orthopedist 30 years ago, you would have got a better assessment than you would today. Anyway, there is a little bit of a start. And by the way, I retired from the university 5 years ago. And I'm based now in Middle Ontario, beautiful part of the country. And we're sitting in BackFit Pro HQ, where we still see patients here. Well, maybe I'll just keep quiet about that.
What changed in the last 30 years that the quality of assessment is so much better?
What a huge question. I think there are many events that have happened, but now in medical schools, even physical therapy schools, very little formal, dedicated effort to back function and how to figure out what goes wrong. Medical imaging is now a substitute for the previous assessment, which involved watching a person move, looking for stress concentrations, performing provocative testing, and actually saying to the person, does that cause your pain? Oh, yes. What did I just do? Now let's give the mechanical antidote. Oh, yes, that doesn't hurt. Or in fact, that even feels better. So they used to be able to converge, as we do today, on activities, specific motions, specific postures, specific loads that cause the pain. And then create movement hacks, if you will, to use a modern day euphemism, around that cause, allow the pain to desensitize, and then build a foundation. But it's astounding to me when, I will say this, and it's absolutely true, that half of the people referred here are caused by trainers who didn't understand training volume and biological adaptation. They didn't understand a human linkage where you need strategic control and stiffness and stability, and you need strategic distal athleticism and mobility. And, you know, if they just went and worked a backhoe for a little while, they would understand how you have to anchor the tractor component down into the ground with the stabilizer bars, and then get the articulated linkage to dig earth, and what are the strong joints and the weak joints, because the hydraulics reduce in their capability as you go distal through the linkage, and the final link is the bucket or the thumb as you're digging earth. Well, I've just described a human. So to tune a body is a lost art. And, you know, I could say the same thing about automobiles, where now the mechanics, the master mechanics, are gone. They just plug the car into a computer, and the computer tells them what part to change.
Do you think that this is partly due to an increased dependence on sort of pharmaceuticals and pain relief and surgical sort of interventions and things over and above, you know, actually understanding what's going on and trying to kind of help with the problem without the pharmaceuticals and the surgery?
Yes, James, that's very wise. There's 2 elements to that. One is it's corrupted by money. And the other, well, I can expand on that a little bit. Clinicians are paid to perform a billable service. Look at what the billable services are. It might be a manipulation, it might be a surgery, it might be a thing or a procedure, whether or not that suits the individual. So, but I'm going to take a step back now and talk about back pain. Let's have a conversation about leg pain. Can you give me an exercise for my leg pain? And you would see the lunacy of that discussion. Well, is your leg broken? Is it burned? Do you have nerve damage? Has it been crushed? Do you see what I mean? There's no such thing as leg pain or head pain. How can there possibly be a thing called back pain? It's simply a symptom. So there's a very broad plethora of mechanisms that lead people to dysfunction and pain. And it's the assessment that allows you to converge on that. Now, instead of going to see a clinician who has a billable skill, you now get to say, well, here's what you need to address that very specific pain pathway. And now you know what to do with strategy rather than dumb luck. So that's part of it. Your government is failing miserably. The NHS in the UK, for some reason, still talks about the symptom back pain, and they'll say, oh, well, here, do these exercises, and the physio will give them a sheet of paper, and the person doesn't even know how to execute the exercise, and whether the exercises have just as much a chance to make them worse as it does better. No idea of assessing the person as to what is a tolerable volume to start stimulating the adaptations that person needs to become pain-free. And then they throw up their hands and say, read this book. And they publish a book called Living with Your Pain. It's an absolute travesty. I'm going to tell you a story. There was a police officer who came to see us in the UK, very solid citizen. And he sat down and just collapsed into the chair and was just sitting like this. And most people sit in their pain, which is rather paradoxical. So the extension intolerant back sits in their pain. The flexion intolerant back sits in their pain. So there he was sitting. So I already generated a hypothesis just watching him sit. And he was telling me about his back pain and how, and then remember, this is a solid citizen. And he started to cry as he told me how he has lost his job because those miserable, incompetent people at the NHS gave him a book on how to live with his pain. And he says, I've given up hope. I'm going to have to live with this pain. And I said, humor me. And I just changed his sitting posture and lead with the chest and extend with the hips and, you know, basically weightlifting 101. But the physios don't know this anymore. And by the end of the session, his total psychology had already changed. He was totally empowered. You mean I have control over my pain? I don't have to live with it? And then he became incredibly angry that he has now lost his job. His family has been compromised because of the treatment of the system, this broken system. So there's a little bit of a political side to your original inquiry. It's corrupted by money and people putting surgical hardware into people because they're very well compensated. Look in the US, a spine surgeon is incredibly well paid to perform these procedures. And the number of times the person would be so much better understanding the mechanism and addressing it. And the last thing they needed was to take a risk with surgery. Anyway, I've talked far too much and I'm sorry about that.
Do you see your role as, I mean, do you have would you say you're kind of, you feel like you're leading a path to something very different? Do you see a calling to change people's perception of how to treat this? I mean, do you have
Well, of course.
Yeah.
Of course. I've been doing that for nearly 40 years now. So people will say, well, can you refer me to a clinician? And I say, well, no, we have to do an assessment first to understand what it is will serve you well. And then we ended up having to train our own clinicians. So if you go to our website, there are the highest level of practitioners, the McGill method master clinicians. And these are all people I've worked with personally. And to make the grade, I will give them 20 back pained patients, all with different mechanisms, and they have to get 18 out of those 20 better. And if they can't shoot 90%, they're not what I'm looking for. Then the second tier are certified clinicians, and they take our courses and they write an exam and then they do a practical exam online with one of our examiners. They are given a case. They have to assess a colleague who's with them in the video. They have to come up with a program, and then they have to coach it. So we need to see them assess, we need to see them coach, and we need to see them program. And however, I haven't worked with them personally, so that's why they're a second tier. But you might find this interesting. When I started the experimental research clinic at the university, we followed up with every single patient we ever saw in the entire history of the clinic. We know what they came in with, what they were diagnosed with. In a 2-year follow-up, we knew whether they even complied with what we asked them to do. We knew who got better, who got worse, and who just remained on the course. So I know exactly our statistics. You show me another clinic or country or insurance company in the world who's done that. Then I ask you the question, there's very little auditing of the medical system for efficacy. And, you know, a person will go to a surgeon and a surgeon will say, oh, well, we have a 90% success rate with this procedure I'm trying to talk you into. First of all, what is the criteria for success? What, you didn't die on the table? Or you're getting back to the things you love. You want to play golf, you want to go horseback riding, and you want to, you know, climb the beautiful hills in the Lake District, say. But people, I don't know why they don't have, there's an entire chapter in my book, Back Mechanic, is surgery for you? And you ask very specific questions of the surgeon. What is the efficacy rate and what does that mean? May I speak with 3 other people that you've performed this procedure on, and I'd like to speak to them and find out how their lives are now. Can you give me those 3? And if you can't, run the other way. But I will say this. We then perform virtual surgery. So no, unless you've been traumatized with really damaging injury, say you've been in a car accident or something like that. But if it's back pain that, if I said to you, do you have better days and worse days? If the person says yes, I'll say, don't you dare have the surgery. If you have a better day and a worse day, there's a cause. Find out what that cause is and get rid of the things that cause you to have a worse day. And anyway, we then try virtual surgery. And virtual surgery this works really well for the exercise addicts. You know, the type of corporate warrior who is your clientele. They're high performance people and they go and blast for an hour or 45 minutes at the gym at night. And it's so unfair. They've got back pain and they don't realize that sitting all day sets them up for pain. And if the programming isn't right in that 45 minutes, it is not an antidote to the sitting all day. It is actually a compounder. So we then say, well, go and have the, and they'll say, well, if I don't go to the gym and ride the elliptical for 20 minutes and punch the heavy bag for 20 minutes, I'm going to murder my spouse. You know, it's my stress reliever. And I said, all right, go have the surgery. Now, the surgery may work, but it's probably going to work because it's forced rest. For the first time, you're cooling the jets. And that sometimes hits home to them. And I say, all right, let's play virtual surgery. There you are. I've just given you surgery. Now start behaving like a post-surgical person. So tomorrow, you're going to take it easy. You're going to do a little tummy lay. You're going to walk, go to the toilet, etc. And over the next few weeks, we're going to build your walking resilience and then strategically tune your body with appropriate mobility and stability, etc. And only create your repertoire of pain-free movement. And I've measured this so I can stand by the statistic. If you fall into the category of this, you've been to a clinician and the clinician says, you've done yoga, Pilates, you've seen the physical therapist, you've been to the chiropractor, you've been to the psychologist, you've had a surgical consult, you've failed. The last thing that will work for you is surgery. If that's the category, so we have to subcategorize the patients, but if you've been told your last resort is surgery, I can tell you that 95% who follow our virtual surgery plan will not have surgery and are glad that they chose that after a 2-year follow-up. So there you go.
It's fascinating.
I was just going to say, Stu, I think obviously you've mentioned the NHS and you touched on the kind of the medical system in maybe the US and Canada. I know is different as well. I know without being political, as a part of the problem with, say, for example, any system like this is so many people seem to have report back pain now. And obviously there's only a finite amount of resources in the NHS for people to be seen and that sort of thing. So what is causing us, in your experience, I mean, the percentage of people now who report some kind of back pain or lower back pain in their adult life is huge, isn't it? And in your experience, why is that? It's a massive question, I know, but
it is a massive question, and I'm trying to get the most simple wording that I can. Most of the time, the vast majority, the person is exceeding their biological tolerance, and so they have pain. So that's it in a nutshell. Now, that biological tolerance could be sitting. None of us are made to sit for 8, and now we have people who go home and watch television at night when they've had a desk job. What are they thinking? You know, if you want to detune and abuse your body, do that. They fail to take short little interval walks throughout the day. So they don't know how, I would say, to reduce the stress concentrations that are causing pain. Now, you're probably aware of the movement in physical therapy. Physical therapy goes through these eras, and we're in an era right now where they've really downplayed the role of posture and movement skill and that kind of thing. And they say that causes fear. Just go ahead and move. And we find exactly the opposite. People will sneeze or bend forward and flush the toilet or pick up a pencil, and they have an acute back attack. This causes PTSD. If I came up behind you and slapped you on the head, and I hid around a tree and I did it the next day, and I hid behind a corner, I did it the next day, you would get PTSD, never knowing when someone's going to come and smack you on the back of the head. And this is what happens with back pain to people. So now we have a psychology of being a victim, never knowing when I'm going to sneeze or bend forward and my back is going to, use the euphemism, go out, or they have an acute back attack and they're miserable for a week, but then it gets better over the week and they're right as rain for 3 months until the next one occurs. If they understood why that was occurring, and it's a very simple strategy to not get that attack from nowhere, then the psychology of being a victim turns into the psychology of an empowered individual who's in control. Do you mean instead of tying my shoe like this, if I could put now this stool's a little tall, just let me lower it. There we are. But if I could put my foot up on the stool, and you can't see, well, let me show you here. I'm just going to, can you see me okay?
Yes.
If I put my foot up and then I'll say, well, lunge and now tie your shoe. And they do this. And I say, well, you just mimicked a open fissure disc bulge, which I'll show you in just a moment. Stay tall, take your hips to the target, let your knee drift over your toes. And you see how now I can tie my shoe. Absolutely bulletproof for that particular injury. I've got all of these models up here, which are made by Dynamic Disc Designs. I'm going to give them a plug. And I have no business relationship with any of these people, but they just make the best biofidelic models going. So let's take your clientele who's an office keyboard warrior who sits at their computer for, say, so many hours a day. And then they go to the gym and someone told them, oh, butt wink is okay at the bottom of the squat, or you can pull with a round back. Good. Well, if you sit and compound that stress all day, you're starting to create the perfect storm. Anyway, inside the nucleus is a hydraulic fluid. It's a gel, the nucleus. The joint of the spine is not a ball and socket joint like a hip or a shoulder. It is an adaptable fabric. And if I wanted to work the fibers loose in my jacket here, I'd create stress strain reversals back and forth, and the fibers would slowly delaminate. People do this with their spines unknowingly. And it looks like this. These collagen fibers are held together by a ground substance, but if you apply load and then keep bending it over and over, the collagen fibers slowly delaminate. Can you see the little red mark in the disc right there? Now watch it. I'm going to squeeze the spine and bend it forward. Do you see the fibers opening up? And I'm squeezing the hydraulic material posteriorly. Now watch. I'm going to, so that's the person sitting down like this, not realizing that that's why they can't sit for 40 minutes. But when they go for a walk, the pain goes away. Why is that? When we are upright, and now I'm going to squeeze the spine, do you see the whole disc squeezes and nothing is driven hydraulically out the back? So when they get out of a chair, sniff a little air, lean forward through the hips and pull the hips through. Now, what did I just describe? Weightlifting 101. So we will get right down to, is that your mechanism? And that's why your back pain starts with 20 minutes of sitting and walking. Now, if they don't walk every 20 minutes from their desk job, and I'm just talking walking down the hall and back, and do a few strategic exercises, I hope they enjoy their pain. But you know, they've been to 20 different clinicians and no one has shown them that.
So
isn't that a tragedy?
It's surprising the lack of communication. You know, and it takes time sometimes to address these concepts initially. But I think once they've been imparted, they will stick with people. I mean, because we're trainers and we often deal with, we deal with the lifestyle choices that people have made, and they have aspirations to live a healthier life. And obviously us three, we all know the limitations of our knowledge. You know, we aren't medical practitioners in any way. We're pretty good at getting people to lift weights off the floor, pick them up, move them around. But what I realize is how much communication I need to make at the start, because I have someone who's a sponge initially. They're very, very motivated, and you're working with people who have a good motivation. Chronic pain, well, it should be a massive motivator. You know, sometimes it isn't, but most of the time it is. And I think a lot of the time, this kind of knowledge isn't imparted up front. There isn't enough time made for it to communicate it and follow it up. And obviously that's what you do. And that's what your practitioners that you train up. Communication is a massive tool. I mean, how are you communicating to people? Because you talk about knowledge being a solution, but how do you communicate the action as well of doing it?
Are you talking to industry or to clinicians or to trainers or a back-pained person who's sitting in front of me?
Well, that's the thing, isn't it? Now it's a little more complex when we start having those multiple different touch points that a person may go through, you know, because they come to trainers because they got back pain. I sat down with someone yesterday. What was the major injury they have? Back pain, you know, but then they'll also go and see an osteopath or a chiropractor or their GP, you know, or they go and see the HR specialist at work to solve the same issue from the same person. From your point of view, I suppose it's quite clear how you communicate because you're coming from your angle.
Well, I'm still not converging on the question here. If your question is, do we work with industry to put a program in place at a factory, say?
No.
I can give you an example of Goodyear Tire if you want to use that one, or a fire department of Pensacola, Florida, or whatever. We will go into that facility to use that as an example. Goodyear.
My question is a question of communication, because on one hand you have knowledge, okay? So you have someone like yourself who has a huge amount of knowledge, and then the next part is you've got to communicate that to someone who has a very complex relationship with their pain, who also has a huge amount of bad habits. And sometimes people will sit in front of you and just nod their head. And so to get them to take action.
Okay, so you're talking about the individual in front of you.
Yeah.
All right. You need to come here to BackFit Pro. They, when I started the clinic at the university, the patients would come in and they would go into a room that won an architectural award for interviewing. Now, the psychologists in our department used it, the physiologists used it, the hand specialist used it, and I used it. And me, the clinician, sits at 45 degrees from the patient. The patient looks at a fireplace and the fire is going. In other words, we're creating an atmosphere that that person will tell you things that they've never told anyone else before. So now we're getting at the real causes. You've been to 12 different clinicians. What was the impediment that caused you to fail 12 times? What has conditioned you to be a failure? So we're getting into some heavy conversations now. And for the first time, we will reveal why they've failed. And now I'm doing pattern recognition. What is their learning style? You might find this interesting. Have you ever worked with an explosive athlete? So they are top fighter, sprinter, whatever, but they're not an endurance athlete. They are an explosive player. Think of those people that you know, and I will bet that almost every one of them would have what some psychologists label attention deficit disorder. They have a very short window in which you can coach them because their brain is already off onto the next thing. So you recognize that. The next person comes in as an endurance athlete. They ponder, they think what you're saying to them. You say, okay, I got a totally different coaching style now. I can explain mechanisms and I can demonstrate to them and show them. So it's a real back and forth. But this idea of empowering a person requires a different coaching style for every individual in front of them. The stories I could tell you, we had one fella who won Poker Stars in Vegas. Do you know the world professional poker? And, you know, I said, you know, I'm not going to let this guy go. I got out a deck of cards and I pulled out a card and I said, what card am I holding? And then what card am I holding? And he was pretty much spot on every time. And then I said, okay, I'm going to show you what's causing your back pain so that you can sit at the poker table for 12 hours and win your next $5 million. You're going to show me what you're reading in me to know the cards. So do you see, I'm learning how to communicate and what turns their crank, what are the cues that they learn from. Sometimes it's physical, sometimes it's this psychological empowerment that I'm talking about. This will be telling as well. If I have someone who, let's call them blue collar, they're a car mechanic or something. Generally, they're dismissed by the medical profession as being not as intelligent as the office worker, and they are treated differently. And then that firefighter, that car mechanic will say to me, Professor or Stu or whatever they're calling me, thank you. You're the first person who hasn't treated me like a 5-year-old. You're the first person who's explained what's going on. Now, if I said to a surgeon, would you give me 95 foot-pounds of torque on that wrench to do up the nut on that car tire? They wouldn't have a clue, generally speaking. You go to the car mechanic, they know exactly what it is. So when I say, you know, when you're pulling a door, pull the pulling force axially through your spine. But if you pull through your shoulder, you've just created a twisting torque, and that's triggering your pain. So do you see I can talk torques, lever arms, and whatnot to the car mechanic? Very difficult to many medical people. So it's a long-winded, circuitous kind of an answer, but there's a start on that conversation anyway. You got to be aware. If you can't read people, you're in the wrong business.
But this is one of the things as well, isn't it? Of what we've just been talking about there is it's ultimately back onto the individual, isn't it? To Yeah, right here, because you talk about in your book as well, non-specific back pain, which there isn't any. It's always specific. There's always a cause, isn't there? So people are like, I've been diagnosed with non-specific back pain and given this book on how to live with it. And it's like, well, there is a cause, there is a way, there's probably a way out of it that isn't surgery 95% of the time. But you're going to have to, obviously, you've got to communicate to that person in the way that you've been saying, in a way they'll understand. But then they've got to then take that and go, okay, I'm going to go and incorporate these things into my lifestyle. And that's where, I think that's where the biggest struggle comes, because when you're not with the person, they might just go and sit at work again all day or whatever. And this is what we were talking about before we started recording, wasn't it? About, getting people to understand their bodies, understand what the triggers are, and then understand how to stay away from the triggers and have an alternative movement pattern, or an alternative to what they were already doing, like a standing desk or something like that. So
I suppose an athlete has a very good reason that they have to be rigid. They have to follow a plan because their career is at risk. Their level of performance is instantly affected by that. And so you see these people, they will be like the military. They'll go through it. Well, you'd hope anyway. And you could probably tell me if that's the case. But I suspect you probably have a higher level of adherence from professional athletes and military than you do with general population. Because I always ask the question, have you done your physio? No. Even because the pain disappears and then they think they're all right and then it comes back again. And so you end up in this kind of cyclical kind of relationship with the pain.
Well, it's a matter of reading that person and what's going to motivate them. Some people, I would just play hardball with them and say, I walk away and I say, I hope you enjoy your pain. Now, they'll say, whoa, what? Wait a second. Or again, what is the missing link? Is it their misunderstanding of the physiology, anatomy, biomechanics, neurology, or is it their lack of self-discipline? They don't eat well. They don't move well. They are content with being third best. Well, that's a whole different conversation than talking to the world's best, who they will not accept second best. And look at eating or success in life. There are lots of people who are content to be unsuccessful. But it's not any of you three, and it certainly isn't me. I don't want to live a life like that. And we have these very deep conversations with people. I should also say that there is a real selection process based on the kind of clinician that they're going to see. So if a person wants to spend 10 pounds and go to the chiropractor and get a quick manip and then off they go, which never addresses the cause of their pain, and they'll be into 10 pounds next week and the next week and the next week. If that's their personality, fine. I charge a lot of money for people coming to see me. They have to travel around the globe to see me. I don't see local people here in Ontario. They all fly in. In other words, they've made a huge commitment and they bloody well pay attention. So that's a very different situation for me to motivate people than, say, when we had the clinic at the university and insurance companies would send us their difficult claims. So these were long-term liability. That's what they call them, financial liabilities, not people. And they want them off the system. And, they'd be opioid addicts and all kinds of excuses. And, invariably, they might even be late for an appointment. How many people do you think come here after flying in from Australia or Asia or the Middle East or Europe and are late for the appointment? Zero. Do you see what I mean? Yeah. But if they're late for the appointment at the university, I would make them wait even longer. And I said, how'd you feel about that? I got you to sit. And what causes your pain? Oh, sitting. Okay. So anyway, and then when a person comes here, And if sitting causes their pain, do you think I make them sit in a waiting room? Absolutely not. We show them right away. And then when I'm interviewing them in the beginning, they may not sit, they might stand. Or I might say, what is the most comfortable position? What is your go-to position of respite? And they'll say, I don't know. And I said, please go get your money back from every previous person that you've ever seen who's never even shown you where your safe place is. Can you imagine the psychology of that has been missed? I've got nowhere to go to reduce my pain. And it's very rare that that position does not exist. It almost always exists.
This is an interesting thing that I was talking to a couple of guys about. One was I was learning a form of therapy from them, and they were saying, you know, like the psychological, neurological aspect of it is massive as well, because you could take my lower back out of me and stick it into somebody who's got low back pain, and take my lower back, which doesn't hurt, and then it would probably end up hurting in them. But if you take theirs, which hurts, out of them and put it in me, because of the way I work and the way I'm like, right, I need to solve this problem, I'll probably be able to manage that back pain in the way like you've been saying, like kind of just finding ways to move that doesn't hurt, and then eventually gaining the confidence of my central nervous system again. So this is getting me to one of the questions that we were actually going to ask you originally, because that's kind of like the I mean, I don't know if you agree with that or not. So you could take my perfectly fine back, stick it in someone who has lower back pain, and they would probably end up experiencing pain in my, like, you know, with my structure. But if I took their structure and put it in mine, as long as it wasn't sort of structurally damaged, there was just some sort of movement that they would do, and you could put it in me, and I would do movement slightly differently, and then the pain might be managed. But the question was,
well,
you know,
may I just interrupt Peter for just 1 second and give a comment on that? It may or it may not be. It may, if you switch spines with someone, what you just said might be true or it might not be.
Okay.
There are many pain mechanisms that are inherent to the spine, no matter who you put them into. When they sit, here, let me give you an example. Here is a pelvis with a lumbar spine. Now, this joint has been damaged. You can't see it's damaged. There's no radiological evidence because the image is a static shot. But now let me show you something. This disc has been damaged with an end plate fracture. You can't see it. If you let air out of your car tire, the car's a bit sloppy on the road, right? This is a normal joint, and this is a normal joint. I'm now going to apply a twisting torque. Where's all the motion? The motion is at the joint that has lost inherent stiffness. The only time you will see that is through video fluoroscopy, which is a real-time moving X-ray of the movement experience, or you might be able to see it on ultrasound, but a good set of hands can also feel where that laxity and loss of stability and control is. Now let's go to the same level in the back. And now you see all of the extra loads that are going onto the facet joints at that level. So let's test those joints. Oh yeah, there's my pain. So do you see what I mean? We'll get to that. So there's a lot of lurking pain mechanisms that the vast majority of clinicians have no skill to converge on. So that's why I say yes and no. The next person has what we call central sensitization, which is what I think the person you were having your conversation with was probably coming from. Let me give you an example. I'm going to take my thumb and I'm going to hit it with a hammer. It hurts. The next day, I'm putting in a nail and I hit my bloody thumb with the hammer again. And it hurts even more because it's already sensitized. Now, the third day, I hit it again. Man, the fourth day, all I do is lightly touch my thumb and I'm screaming. Or if I stub my toe and I keep stubbing, or I bite my tongue and I keep biting it, you create a central sensitization. And it's a sensitization that is more than just the injury. So In that case, I would agree with you that you could take your spine and put it into a centrally sensitized nervous system. But the key there is take the hammer away. Stop stubbing your toe. Stop sitting in the way that's causing it, or lifting in the way, or doing Palloff presses. Could you imagine if you gave this client a Palloff press so that you hold a cable, pulling that way, you extract your arms, and it does that to the spine? It just triggers the pain. It would be absolute poison to give that particular pain mechanism a Palloff press. I'd be so better off turning it into a 3-point bend, a side plank with a front roll and an elbow tap, or something like that, which takes out all of the shearing load that I just showed you. So anyway, do you see why I would say yes and no? It depends entirely on the mechanism with that person. Anyway, you can carry on now, but I thought I'd just...
I do see that, and I knew your answer would be it depends, because it always is.
Well, we're dealing with people.
Absolutely.
And people with a symptom.
Yeah. But this, so one of the questions was that we had that I had at the very beginning was like, can you blame like your genetics and family history and stuff, like you can with like, sort of like heart attacks and things like that. And if you've got a family history of this sort of stuff, can you have that with back pain as well?
Absolutely. But if you would allow me to get off the back pain symptom and talk about back pain mechanisms, then I can discuss that. Let's look at the incidence of orthopedic disease around the world. So you're aware that certain organic systemic diseases hit different gene pools around the world in different ways. There are people who are intolerant of certain nutrients, for example. All of this is genetic. Let's go across Caucasian Europe. Where is the highest incidence of hip dysplasia in Caucasian Europe? In other words, where is the hip socket the shallowest? So if I took a model like this, and there's a hip joint, a ball and socket joint, who has hip dysplasia so that the ball can slip out, and it's because it's a very shallow hip socket? It's in Poland. Poles have the highest incidence in the world, along with Okinawa and Japan, of hip dysplasia, but they have the deepest squat. So with a shallow hip socket, you can squat right down, ass to grass. And where do the Olympic lifters come from? Poland, Eastern Europe. Now, how many Olympic lifters come from the Celtic nations? Normandy, France, Scotland, and Ireland. The answer is pretty close to zero, because they have the highest incidence of FAI, femoral acetabular impingement, in the world. They have a very deep hip socket. It's called a high roof. So now the hip is impinged right there with a very deep hip socket. So should that person be deep squatting? Absolutely not. Their strength, when you measure the power profile in the Celtic hip, the power is in the top half. They fail pulling the weight off the ground. They never fail at lockout. Once that weight passes the knee, the Celtic hip, boom, it's power. Now let's look at the indigenous games. This is the Highland Games. It's a standing strength. It's the caber toss. It's the weight throw. But that's not what would be in the Ukraine. It would be a deep squatting. And the power out of the hole in the bottom of the squat is ungodly. They fail at lockout. So anyway, that is my first bit of evidence to show that architecture and neurology sets up incidence of orthopedic disease. Now, both of those examples I gave you were stress concentrations. We see exactly the same thing in spines around the world. So one of the highest incidents of spondylolisthesis are among the Canadian Inuit, our northern native population. Their facet joints are angled this way, which every gymnast, who gets spondylolisthesis in athletic populations? See, injuries cluster around sport for a reason. Certain genetics are needed. In other words, if you're a person like me with closed facets, the facets just glide back and forth in flexion and extension. There's no stress. But if the facets are orientated this way, it now means I've got a huge ability to twist. but they're like shingles on a roof. So when I bend back, they bend the pars bone instead of gliding by one another. So the very architecture that gives a person the advantage to be a gymnast is the architecture that causes a stress strain reversal on the pars bone that holds the facet joints on. So do you see the architecture gave him the ability to be the gymnast, and then the stress strain reversals from gymnastics creates the stress concentration only on that particular architecture to cause the spondy fracture. So do you see why it's very genetic?
So would you say though, genetics, I mean, when we look at elite athletes and there is a genetic selection, you know, I'm never going to be a 100-meter sprinter. I just know that I have the fast twitch, explosive power. But they're the outliers. They're at extreme ends of it. Given that most people sit right slap bang in the middle of being, you know, just everyday people going to walk to work or whatever, can you blame your genetics if you never really put your spine under those extreme loads?
Partly. And I say that because it's not extreme loads that causes most people's back pain.
Yeah, no, that's true.
So let's look at what causes cumulative stress to cross the biological tipping point. So a force or a load has magnitude. So if I pick up 100 kilo off the floor, there you go. It also has a duration. So if I sit slouched for 5 hours, there's a creep that has taken place in those structures. And now they as the structures have been creeping, they lose their ability to bear a load. So it's time or duration. Then it's repetition. And then all of those factors are mitigated by rest. See, the language of cells and adaptation are mechanics, is force and load. So cells communicate with load. We train to create stress concentrations, and then the body adapts. It's how we build bone. It's how we build tendon and muscle. If the signaling then stimulates an adaptation, and we don't give a rest period for the adaptation to occur, all we did was create cumulative micro trauma. So the adaptation schedule is genetic. So I don't want to default on this because it's an easy way out for people to say, oh, I'm going to blame your genetics. There's nothing you can do about your genetics. You've got to live with the constraints that God gave you. And there are those elite athletes who've been touched by the hand of God, and they can violate the biological rule book that we all live under. And that's the gift from God. You and I don't have that. But there's a little bit of a discussion on where that cumulative stress comes from. It's magnitude, it's repetition, it's duration, mitigated by rest. And that's a programming. What you do, it's an art and a science. You screw up a couple of people and you say, geez, I'm not going to do that again. Next time that same pattern walks in through the door, and I'm going to back off on this, I'm going to lay it on a little bit more. To become a master of the craft, a master trainer, takes a long time.
So as one question that we emailed you, we kind of characterized an unhealthy spine, but it's often on the opposite side of a very healthy spine. So, I mean, you must see people coming in all the time with unhealthy spines. What characterizes health? What do you think the natural place? I mean, we're an upright bipedal creature that comes with compensations. What is it to be healthy with your spine?
What a brilliant question. It's a seminal question. What do you mean by healthy? Well, let's break that down a little bit. Do you mean pain-free? I know lots of absolute couch potatoes that are a heart attack waiting to happen, and they never have any back pain. So I can't use pain-free as the metric for spine health because they are a sloth and have no capacity. They'd be so easy to break, but they never stress, so you never find that breaking point. So that's not health to me. Do you mean strong? Do you mean Do you think a power lifter who wears Birkenstocks because they can't tie their shoe, but they don't have any back pain, they're incredibly strong, is that healthy? No, they're pretty damned easy to kill because they're unidimensional in their athleticism. Then we go to someone who's a real mobility monster. They love yoga and they're very, very good at it. They tend to have, I mean, you can't take a thick spine and ask them to do yoga. It will cause them difficulty and pain. So a yoga body is a slender body by definition. You know, if you take a thick tree, you bend it and it shatters. You take a thin willow branch, you can bend it back and forth because it doesn't create stress. So stress in a spine is a function of its thickness or radial distance. Anyway, my point in all of this is it's very difficult to say what is a healthy spine because there's no context. So now let's say you can't have it all. You can't be a thick, strong power lifter who needs supreme stiffness and stability and ask them to do yoga. Nor could you ask a yoga monster to do a deadlift. It would just be silly programming. So the body, first of all, there's a genetic background, and then you adapt the body to do something unidimensional. A power lifter is a very unidimensional athlete. A golfer is a very unidimensional athlete. Look what's happened in the world of professional golf over the last 15 years, where someone said, oh, start doing Olympic lifting, and magnificent careers blew up. You can't have strength and be a great golfer. A golfer is an elastic athlete where you're tuning the storage and recovery of elastic energy, a perfectly timed pulse as you come through impact. I mean, the science of it, if you try and hit a golf ball very far and use muscle, it doesn't go very far because the muscle creates stiffness as it contracts. So do you see where this conversation is going? Give me a context. Now, if a healthy back is your client, as you mentioned earlier, they want a little bit of everything. They want a little bit of stress-free mobility. They want to walk in the hills. They want to go cycling, swim, all of these things. By definition, you can't tune the body to be a specialist. In other words, you can't be flexible and bear a lot of load, and vice versa. So the key to training that person is to give them a little bit of what they need, realizing it's all a game of trade-offs, and don't overdrive one of those variables. But why do I get patients here? Because some trainer thought it was a good idea to give them deadlifts off the floor. This is a stay-at-home mom who, what causes her back pain is picking her child who weighs 5 kilos out of a crib at 2 in the morning to feed them. What that trainer should have done is teach her how to pull a sandbag close to her body, hip hinge lift, and the transference. And I'm one of the few guys in the world who's measured transference of training things like deadlifts and whatnot onto real life. A deadlift doesn't transfer to her picking up her child. So there's an example of customizing the programming to be healthy in that context. But she's not going to win anything. And then the next person comes in, just to give you an example, and I'll say, well, what are your goals once we get you out of pain? Oh, I want to play golf. Or no, I want to deadlift 200 kilo off the floor. That's my goal. And I said, really? I said, well, why do you want that goal? Oh, it's cool. It's on social media. Or I read on social media that every woman should be able to deadlift twice her body weight to be a real woman. And then I'll say, but you realize that you've just shortened your athletic career. That athleticism you develop will be very short-lived. And then you'll have to live the rest of your life. Let me ask you a question. If I said to you, you can be the best granddad on this planet. You will play with your grandchildren when you're 70 years of age, pain-free. How do you like that for a goal? Because if your goal right now is to deadlift 400 pounds, you probably won't make that. Now that is a very sobering discussion. No one has ever really thought about what that goal of training is. And when I switch the psyche to, I want to be just a rockin' granddad. Now that just changed our whole training philosophy. That is spine health.
Mm.
So you're saying that no one could come through a specific athletic goal unscathed, in a way?
How often do you work with surgeons and go into the office and see who's sitting in the office waiting for the next hip replacement, knee replacement? Let me ask you another question. I don't know if you have any clients in masters athletes, but I've had many set world records, strength sports, speed sports, masters Olympians. My wife was a world champion heavyweight rower. My point is, how many Olympians are winning the Masters Olympics?
Yeah.
Yeah.
They're all used up.
Yeah.
I mean, look at your pro athletes. You know, I had an American footballer here who was in his early 30s, 2 artificial hips, 2 artificial knees, looked like a Greek god, but, you know, he couldn't get on the floor.
Mm.
Now, where's he going to be in 20 years? Every year you play in the NFL takes 3 years off your life, statistically. You know, I can keep going this way if you want, but the more fit you are now, okay, let's talk about CrossFit. Do you think those people who are competitive in CrossFit now are going to be rocking and rolling when they're 55?
It's we've had Dan John on four times actually, and we often have the discussion around the difference between you know, health, fitness, performance, and longevity, and how they're kind
Right.
of, you know, the performance really doesn't have anything to do with health. You know,
it actually does. It's antiphasic.
Yeah, sorry. Yeah. Well, yeah. I mean, sorry, a high level of performance doesn't mean a high level of health. Yeah, kind of. Yeah, the opposite.
that works really well, actually, because I mean, you know, the rock. I say that to the guys I train all the time, and the ladies, where, you know, it's like, if you want to be able to play with your grandkids, you know, because most people now, the people I train, guys in their 40s, you know, they might have, like, you know, kids who are 10 years old, and they're struggling to play football with them or something like that. And I'm like, okay, so you're certainly, if you're struggling now, you're not going to be able to play football with your grandkids, are you?
Well,
but if you can work on it now, you might be able to in the future. So, look at
the people who you consider to be healthy and able in their, well, I'm mid 60. I'm exactly the same age as Dan John. I have exactly the same. I've had the same surgeries as Dan. We are a couple of peas in a pod. We both have artificial hips. You'll notice Dan, John, and McGill and where our parents came from. You know, he's Irish too. Anyway, he's stronger than me, though. I'll give that to him. But anyway, where was I going with this? What are the characteristics of those people who you consider, in your expertise, are healthy spines and they're 65 and 70? Now, look at what they did for their life. They were somewhere in the middle between an athlete and a couch potato. And I can tell you now, I wouldn't have said this when I was 40, because when I was 40, I used to strength train heavy. I didn't need mobility. I had it. God gave it to me. I sure need it now. I mean, you know, I've broken my neck, my collarbone, ribs, broken my hips. You know, I've got a lot of mileage. But now my training week is 2 days. I do heavy physical labor as well. So that checks the boxes for a lot of things. But I get up at the same time every day. 2 days a week, I strength train. 2 days a week, I work on the things that are stuck. So a little bit of mobility. And 2 days a week, I work on something that's for my ticker, you know. And then 1 day a week, I don't do anything. And when you look at every major religion has a day of rest. And remember that biological adaptation that I was talking about? That's why we train, to stimulate. You got to give it the day off. And here at BackFit Pro, my daughter, Sarah, has created such a whole new element in terms of optimizing the adaptation, which is something that I never really developed here at BackFit Pro, and then she came along and did it. So, I was about stimulating the adaptation, and now she's brought in the rest and relaxation. How do you potentiate adaptation? In any case, there is a training schedule that fits 60s, 70s, and even 80s. And if you go out and split your firewood, so we heat with wood, I split my own firewood, I don't need to strength train that day. Nor do I need to do any mobility training, nor do I need to do any cardio. It was all in that activity. But some days I'll look at it, I'll look at my past 7 days, and I'll say, I'm going to go for a bike ride today. And the other key is don't do two things. Don't do the same thing on 2 consecutive days. And it's how you stop flaring up the old histories. So how about that for back health, Paul?
I love the thing as well of being the guy. This is who I want to be. You say, like, who do you look at and what do they look like? I want to be the guy who's 65, 70, 75 years of age, who people come and knock on the door and go, I'm moving it. Like Dan John talks about, I'm moving a sofa. Can you come and give us a hand? And it'll be like, yep, I can, because I've got all the time in the world, because I'm retired and all of that sort of stuff. And I've still got my health and strength. And,
can you come and help me change my toilet? You want to be careful with that one.
Yeah, but it's just being handy, isn't it? It's like, that's... Yeah.
I was going to say, I trained a gentleman this morning, Ray. I'll give him a shout, Ray Moore, who's been training with us for at least 10 years now. And it was his 68th birthday today. And we had a really good session. And then he was going off to join. He's never sailed before, but he wanted to learn to sail. So he's going off on his 68th birthday to join the local sailing club. And a guy came in to train after him. And I said, oh, Ray's, it's his 60, he was 68 today. And he goes, God, he looks good, doesn't he? He said he thought he was probably like mid to late 50s, and this guy, and it's exactly what you just said, Stu, he's a professional kind of man. He's not ever really caned it and pushed himself hugely, but he's just stays fit and healthy. He walks he does a lot of walking, which I know is obviously a major, part of your programming. He walks the dog every day. He's got grandchildren. He's not abused himself to any extent throughout his life, and he's fit and healthy. And I think at 68 years old, that's it's the kind of thing we're talking about, isn't it? Health.
Yeah. In your profession, I mean, that's great wisdom, what you just said, James. It's so difficult to find trainers who aren't chasing the next fad and pushing. I'll talk to their clients and they'll say, oh, I had a great workout today. Am I ever sore? And I thought, I guess we'll be seeing you when you're in your 50s and 60s. But, I used to say things, and I've learned just keep my mouth shut. When they'll come when they need to.
I was just going to say, Stu, I think we've gone just sort of about the hour, or maybe even a little bit over the hour. And I'm really conscious of your time, and you've joined us. You've been so generous with your time, and it's been an absolute pleasure and so interesting talking to you. And it's been everything I hoped it would be and more, to be honest. If people want to, I mean, we obviously have listeners all over the world now. But if people want to find out more about you and what you do, and maybe if they're a person, an end user, if you like, a patient, or if they're a clinician or a therapist or someone who's interested, where's the best places for people to come and find out about you and your work and the education that you spoke about earlier for professionals as well?
Our website is backfitpro.com. Backfitpro.com has 2 entry portals. It asks you as soon as you're on the front page, are you a patient or a person with back pain, or are you a clinician? So you enter both ways. And the resources for the clinicians are our courses, which are now online, our books. There's some videos, and there's lots of papers. I mean, I've published, 250 medical papers, and etc. And then for the person with pain, we introduce them to our various master clinicians around the world, our people certified. There's access to our books. If sitting causes you grief and you put your hand behind your low back and sit back and say, oh, that makes my pain relieved, then we have various pneumatic supports and things like that. So there's quite a few things, resources for the person who has pain. So that's, they don't need to find out about me or anything like that. Just go to the website.
Fantastic. Peter, do you have anything you'd like to say, or any final thoughts or questions?
I just love hearing about this stuff. And I love the way Stu explains it as well. I've listened to you on, I've read your books and I've listened to you on many podcasts and stuff like that, and you just explain it. It makes so much sense. And I just think everybody should listen to you at least once, and then at least they can...
Pete, could you talk to my wife? she thinks I'm an idiot, like most wives do of their husbands, I'm sure.
No, honestly, I do. I think you've got this ability to just, and I know when you think of an answer, you're like, right, how do I put this in terms that everyone is going to understand this? Because obviously you could go off and talk how you talk at university or whatever, and everybody be like, what on earth are you on about? But you've got such a good way of explaining it, and it makes, every time I listen to you speak, I'm like, yes, my back's going to be better because of this. Even though there's nothing wrong with it, or there's nothing wrong that I know of with it, I'm like, it's going to be better for longer now. So I love it. And I recommend your back mechanic book as well.
Excellent.
Here.
Mr. Paul Bassett, any final thoughts or anything you'd like to say?
I've got one question, and this must be a question. I'd be interested to know how you handle it, because someone like yourself with your expertise, everyone you must meet must ask you about helping them about their back. You know, my wife's a dentist, and she gets asked about teeth problems. She gets told about everyone's tooth problems. Do you get told about everyone's life story about your back?
I used to travel a lot pre-COVID, and I'd sit on an airplane, and the person beside me invariably would say, what do you do? And I would say, I'm a firefighter.
Yeah. Simple in life.
Yeah. Or another one was, I'm a plumber.
Yeah.
And I knew enough to fake it.
I'm gonna say,
well, you can put your own toilet.
Otherwise, I was a captive hostage, and I would have to listen for 4 hours or 8 hours or whatever the flight was about their whole family and their back troubles.
And then it would end up like Airplane, wouldn't it? Where you've hung yourself in your seat.
Yeah. Dearie me. Thank you so much, Stu. That was absolutely brilliant. And it was an absolute pleasure speaking to you and meeting you in person. Can I just say, guys, if you are listening, please make sure you like, subscribe, you share. And if you're able to leave a review on the platform you're listening to, please do leave a review. You can also join the closed Facebook group by searching it on Facebook. Just search for Health Oddity and you will find us on there. And like I say, we are closing in. I think next week is our first birthday. It's our 52nd episode next week, which will be an episode specifically with myself, Peter, and Paul, talking about the last year, all the great people we've spoke to, and what we have learned and took away from that, and what we hope to do going forwards. But if you'd like to say goodbye, Mr. Peter Lance.
Hurrah.
If you'd like to say goodbye, Mr. Paul Bassett.
Goodbye.
And thank you once again, Stu. Thank you so much for your time, for your wisdom, for your patience, and for your thoughtfulness as well in answering the questions. I think it's been absolutely fantastic, and the listeners are going to love that. And I'd recommend everyone to check out BackFit Pro, to check out Stu's work, and to seek him out on social media and on the internet. Thank you so much, Stu.
Well, James, Peter, and Paul, thank you very much for all that you do and your professionalism and helping to spread the word. I thank you very much.
Brilliant. Thank you, guys. We'll see you next week. Take care. Bye-bye.
You've been listening to Health Odyssey with Peter Lant, Paul Bassett, and James St. Pierre. To get your regular fix of hype-free health, you can subscribe and leave a review wherever you get your favorite podcasts. You can find out more on today's and other topics at healthoddity.com or find us on Facebook or Instagram by searching for Health Oddity.